Hello, everyone, and welcome to the webinar. Today, we have our topic continues to be opioid safety and efficacy. This time, we're going to focus on some data-driven improvements that you can implement in your practice. My name is Amber Rogers, and I work for Mountain Pacific Quality Health, and I am pleased to introduce Stevi Sy. She is a clinical pharmacist as part of her job, and then she also works with us on the quality improvement side. So her real life experience in providing healthcare is definitely important with this particular topic of opioid safety. If you remember correctly, last time, for those of you that joined us in the previous series, we talked about how providers and clinicians can assess for patients' perceptions of pain. Really highly encourage doing some opioid risk assessments within the clinical practice setting, and really talked about some patient engagement strategies to keep folks involved and so that we can actually change the prescription of any opioids that are going to be developed over time. So this is the second in our series, and we do have one more. So I hope that you continue to stick with us for the next 2 weeks, where we will talk more about some of the actual prescribing guidelines for both opioids and for some the non-steroidals. Couple of little housekeeping items for you. Number one, we do offer nursing continuing education credits. If you do want to receive nursing education credit, you must complete the survey, the evaluation at the end, and you must put your name. Just so that you know, I can't tell if you rated us poorly just because your name is on there. It doesn't work like that. So it's still blinded, but I need to know your name so I can offer you a certificate. Also, you do need to stay for the entire presentation in order to qualify for credit. And the final disclosure is that nobody here has a vested financial interest in this particular topic. And this project is financed in part by a HRSA grant in Montana that is helping folks decrease opioid use disorder in northeastern Montana. So with that, I will let Stevi take it away, and I hope you, another little disclosure for you. Please feel free to chat in any of your responses or any questions to any content that Stevi is talking about. If you have, near the end, if you have a specific question that is perhaps more involved, just click raise your hand at the bottom of the screen, and we will promote you to a panelist, and you will be able to speak and have a dialogue with Stevi about these topics. So chat freely. Let us know what you need in terms of this kinds of conversation around opioid prescribing, because we are here to help you help yourselves and improve care to your patients. So take it away, Stevi.
Thank you, Amber, and thank you everybody for being with us today. I'm excited to continue our conversation around opioids and safe opioid prescribing. Today, we're going to talk about prescription drug monitoring programs and how to best utilize that prescription drug monitoring program, also known as a PDMP or a PNP, and the reports available there in pain management. We're going to identify potential areas of quality improvement monitoring to improve opioid prescribing safety. We're going to talk about evidence-based interventions for safe opioid prescribing. And then lastly, we're going to talk about morphine milligram equivalents again, and how they relate to the risk of respiratory suppression and or breathing emergencies. You will typically hear me talk about respiratory suppression and overdoses in opioids as a breathing emergency. There is good evidence that this is a patient-friendly term that feels very destigmatized, where people are more accepting of that education. So keep an ear out for that breathing emergency. I would encourage you to consider that in your conversations with patients as well. It's definitely less loaded than terms like overdose, and more understandable than respiratory suppression. So to kick us off today, I wanted to talk briefly about some current events, not as current as they were in January, but current events around the prescribing of controlled substances. We're going to talk about federal and state regulations and how things have changed in 2020 and 2021. Primarily, the 2018 Support Act, which required electronic prescribing of Schedule 2 through 5 controlled substances under the Medicare Part D or Medicare Advantage plans, began January 1st. There were lots of things that happened at this time. One of the big things is this rule, the compliance date for it was changed in mid-December to January 1st, 2022, but it still went into effect on January 1, 2021, so this year. And one thing that happened is a lot of the Part D and Medicare Advantage drug payment programs switched to flip on the back end of their programs to where payment is stopped for these prescriptions if they are not electronically prescribed. In a pharmacy management software system, the pharmacist indicates how the prescription was received. This is to meet a lot of different federal and state requirements. So that gets reported to the insurer or the payer, and that allows them to proceed and provide payment or to reject it. And on January 1, we did see immediately many Part D programs went ahead and pulled the trigger on this. They were ready to go, and they will stop payment, like I mentioned, for a lot of these prescriptions if it is not electronically prescribed. This is a burden because we were not necessarily ready in the clinical world. There are barriers to being able to electronically prescribe controlled substances. Your EHR vendor has to be certified that it's safe for electronic prescribing of controlled substances. You have to have all of these validations done on the practice side that, we get chips and two-step identification and all of these keys that allow this to go through. And if those things are not in place and all of the processes that send it, so it goes from your EHR to a processing hub like SureScripts is one, and then it goes on to the pharmacy management system. And if all of those pieces aren't in place to where your verification that you're able to do this based on the qualification of your EHR isn't switched on and isn't working, it can get hung up in there. The end result is there are patients that are not able to get their medication in a timely manner, which is a problem for a lot of different reasons. And because it's tied to payment, there is not a lot of wiggle room to bypass this system. The patient can often still pay cash, but that's an access to care issue, right? Often these prescriptions are expensive. We're talking about a lot of people that have limited incomes, many issues involved when our insurance doesn't work the way it's supposed to. So that began January 1, 2021. It's also inconsistent across the Medicare platform because Part D and Medicare Advantage pharmacy benefits are managed by external contractors. The patient's plan will determine whether or not there are allowances to these barriers and hiccups. And so that has made it an extra confusing time for patients, for pharmacists, for providers trying to take care of these patients. So the landscape is changing. On the backside of this, there are many states that are changing their requirements, and we'll talk about that in a moment. But there are also some positive things that went through with the Support Act. So at the same time, when they switch on flip that switch, requiring the electronic prescribing, they also are supposed to give tools and resources to the provider that should integrate with the EHR. So one of those examples would be the ability to have access to this real-time benefit tool where you would submit an electronic prescription and immediately the Part D program would let you know whether or not the product is on formulary, whether or not it is, tier 1, 2, or 3, so you can get an estimate of the cost to the patient, whether or not there's something more cost-effective available to the patient, so that you can decide in real time what meets the needs of the patient, and then can proceed armed with knowledge of, okay, I know I'm going to need to do a prior authorization because we really need this tier 3 medication, or why, yes, that tier 1 medication will work just fine for this patient. I can switch it to that, and allows you to take care of some of those clerical issues and administrative things while the patient is still in your office, so that you don't have to wait for the fax or electronic message or however you receive notice that people need a prior authorization. You don't have to wait for those things. You can handle it in real time, which is a nice benefit, assuming that it works. There are obviously some connectivity issues for many of those things, especially if you use a smaller vendor. But as we work on interoperability and a lot of these requirements, in theory, these formulary issues will get easier to handle, which is very exciting. Circling back to the electronic prescribing of controlled substances, many states have enacted their own individual mandates. Controlled substance prescribing is federally and state regulated, so the stricter of the two laws applies. Part of that Support Act really helped encourage many states who had been slow to require electronic controlled substances to jump on board. And so you'll see there's a large list there of states that currently require electronic controlled substances. More are coming. Washington, Colorado, Kansas, and Florida will add controlled substance requirements this year. And then early next year, on January 1st, 3 more states will fall in there. There's legislature pending in several other states. New Hampshire, Nebraska, and New Jersey were listed in the resources that I saw. These come from industry, where the different companies that certify EHR for electronic controlled substances carefully monitor this because they have monetary incentive. But I would venture to say that that legislation pending list is actually quite a bit longer. I saw sample legislation for Montana. I know many of our states are currently in legislative session, and so this could continue to grow. These state mandates are different than the CMS mandate, so they would apply to all patients unless there is a carve out. And for these mandates, most states do have a pretty lengthy list of exemptions from that mandate. It has to do with how many patients you have, how many controlled substance prescriptions you write, and then many states are allowing you to apply for a 1-year waiver from those requirements, so that if your EHR is not quite robust enough to get you up to speed to where you can submit electronic controlled substance prescriptions, you can apply for a waiver so that you have a year to get that process figured out. I don't expect this to go away, however, so I wouldn't wait too long for those sorts of things. And if you happen to practice in a state where it's not currently required, be aware that those federal rules will still apply, particularly for your Medicare population. So for a pediatrician in Alaska, it might not be as big of a need at this time, but anybody who's participating in those government programs should anticipate that those regulations will continue to grow and build. We're very curious to hear how that is going. I mentioned we had several hiccups where patients were not able to afford their medication and it couldn't be paid for by their insurer because it was not able to be sent electronically. I happened to work the first weekend of the new year when this was brand new for Wyoming. We went into effect 1/1/21, both for CMS and for our state regulations. So you would really look at the patient's insurance to decide whether or not you could utilize a waiver. For example, if their EHR was down, we can accept paper prescriptions in that situation. But again, it doesn't make a bit of difference if the payer requires that it be electronic. So many nuances there, very confusing, new to the landscape. So I would encourage lots of good communication with your community, get familiar with the state laws because these are all state and federally regulated. There will be differences everywhere. So know where you're practicing. And if you have a patient that is planning on crossing state lines to fill a controlled substance prescription, they're going to need to do some planning and some homework in advance to make sure that they have access to that medication because it might be different in your neighboring states and they should go off of the requirements in your state where you prescribe and wrote the prescription, but that gets very confusing very quickly. So things to think about as we move forward in our controlled substance prescribing. I wanted to give a brief reminder of what we talked about last time. So we did review the CDC guidelines for prescribing opioids in chronic pain. I'm not going to touch on all of these, but I did want you to have them here just in case you need to refer back to them. So opioids are not first-line therapy, but we do often still use them. We need to establish good goals. We should use immediate release opioids, use the lowest effective dose when we're starting out. We like to keep it below 15 morphine milligram equivalents a day. We should definitely avoid increases above 90 morphine milligram equivalents per day. There is a brief recommendation in there about acute pain. We'll talk about acute pain the next time we meet. We're going to evaluate our benefits and harms frequently. We're going to mitigate risk. And then today we're going to talk about reviewing PDMP data. So these two things, the using strategies to mitigate risk and reviewing our PDMP data will be the bulk of our discussion today. And I just wanted to point out in there, when we talk about reviewing the PDMP data, there's sort of a range of what is recommended. They want you to evaluate with PDMP when you start opioid therapy, and then periodically can range from every prescription to every 3 months, depending on the patient, your clinical practice, all of those things. I will say with the pharmacy that I practice with, we are required to review the PDMP data with every prescription. And initially that felt like it would be a big burden, but it only adds approximately 60 to 90 seconds to the processing of every controlled substance prescription, which in the grand scheme of things is not a very big burden. And we are not able to be integrated with our PDMP and my pharmacy management software. So I have to log into a separate program, access the PDMP data, and still it only takes that 60 to 90 seconds. So I would encourage people, don't let that time concern be a barrier. The more familiar you get with it, the more friendly and easy it becomes. The final recommendations in those CDC guidelines involve urine drug screening, avoiding concurrent opioid and benzodiazepine prescribing. That one is important, but when we talk about PDMP data, we're going to talk about CNS depressants, central nervous system depressants in general. Benzodiazepines are the biggest risk when we're combining them with opioids in terms of causing a breathing emergency, sedating a patient beyond safety, those sorts of things. But there are many, many other medications that we should be concerned with when we are screening in the PDMP, so we're going to talk about that. And then lastly, we need to be prepared to offer treatment or arrange for evidence-based treatment for opioid use disorder. So let's talk about prescription drug monitoring programs. Prescription drug monitoring programs have been around for a little over almost 2 decades now in many states. They are state organized and state ran. So to that end, every PDMP system is different. We do currently have PDMPs in all of our states, with the exception being, we do have one state where it's not actually a state PDMP, it is a city PDMP that expands to cover most of their state. So an interesting situation, I believe that's in Missouri. But otherwise, large systems of prescription drug monitoring programs that can be utilized. Many states now participate in the interstate exchange, which is managed through the National Association of Boards of Pharmacies. That has helped a lot with standardization of PDMP data, who has access to it, how it can be used, but there are definitely still nuances in every state, so be sure you're comfortable with your state's PDMP, the surrounding states if you need, or know how to access, like for example, in Wyoming, I can log into my PDMP and through the Interstate Connect, I can request data for my surrounding states. So I can look at Colorado, the Dakotas, Utah, which is very important because in our rural states, we often have people who travel and lots of reasons to go outside of the state for care. So it's important to be able to look at those things. A prescription drug monitoring program is an electronic database that tracks controlled substance prescriptions. It's state statute driven, how often those things are reported, but for the most part at this point in time, they're almost real time. Most states require that these be reported within 24 hours. They do tend to be pretty accurate. You do still, the first thing you have to do when you notice that it's like an issue, you have to verify that it is accurate. But you can trust the information in there for the most part. In addition to, in particular, with conversations with your interdisciplinary team, so the pharmacy serving the patient, other healthcare professionals helping care for them as part of their team. It's another tool in our tool belt that allows us to know extra pieces of information about our patients so that we can take better care of them. This can be used to help identify patients who might be misusing their prescription opioids or other prescription drugs. You can identify frequent fills, anyone who appears to be accessing several healthcare professionals. These are typically actively managed, which means the state has delineated different triggers they would like so that it can generate proactive reports for authorized users. For example, when PDMPs were relatively new, many of us received these unsolicited reports letting us know that a patient was accessing care through several providers or several pharmacies or sometimes both, and allowed us to start having those good conversations about why that's not safe, the risk for patient harm, those sorts of things. More and more frequently, we're able to utilize it also to calculate our daily morphine milligram equivalents, look for risks there, so that if you're a dentist taking care of a patient who has chronic pain, you can immediately pull up and look at what all are they on so that you can have, you can make more educated decisions about pain management for that patient in that particular situation. Because for better or worse, patients are often not accurate historians when it comes to their prescription medications, and prescription directions can be confusing for many patients. So it gives us another way to verify these pieces of information. When you're using the PDMP, this is a clinical tool, and we should try to use it as evidence-based as possible. So a common checklist for PDMP use involves reviewing the providers from whom the patient is receiving their prescriptions, just that quick check of, do they have a consistent primary care provider, or are they seeing a pain specialist? Like, what does this look like for this particular patient? Do I have any concerns? You should be able to use it to calculate the total amount of opioids prescribed per day in morphine milligram equivalents, so that we can get that apples to apples estimation of what their risk is for a breathing emergency or other adverse events. It can allow us to screen for other drug interactions. Most PDMPs do not just collect controlled substances. They also often collect other medications of concern based on statutes. So for example, in Wyoming, we also are required to report certain muscle relaxers. So Flexeril is one of them. We also submit tizanidine, and we submit gabapentin. So Flexeril and gabapentin in particular are being monitored by our board to determine whether or not we want to schedule those in our state, and it requires data to do those things. This is how we scheduled in Wyoming tramadol and soma prior to them becoming federally scheduled. And so it just gives us extra pieces of information, like I said, to do that detailed drug interaction screening. For most states, Schedule 2 through 5 will be reported on the PDMP. That will capture a lot of these concerning central nervous system depressants, anxiolytics, so like our benzodiazepines would fall into that group, and then hypnotics. So these are things like our sleeping medications. These are all medications of concern when we're prescribing opioids. And so it allows us to really look at the complete picture for the patient, because not all of these things necessarily come from your office, and so you might not be aware of them. And patients can innocently just be forgetful that they received something from someone else. A common thing that I see is patients receive treatment from a qualified dentist for some TMJ issues, and they know they feel better, but they don't necessarily know what medication they were on. And it turns out often it's a benzodiazepine for those sorts of issues. And so having that knowledge, should the person sprain their ankle, is very valuable. So you can pick better pain management for them. And this also allows us to assess for other red flags, so we can start having those conversations if we're concerned about a patient. Are we seeing frequent fills? Are we seeing multiple providers on here? Are they accessing the emergency department frequently? Not all of these things are necessarily indications that this patient has a substance use problem, or that we need to be worried that they're diverting their opioids. It typically is not those things, right? It's usually an indication that the patient has an unmet health need, or that they're missing a key piece of education. It allows us to start really digging into what is happening with that patient compassionately and with more knowledge, so that we can get to the bottom of what's going on with them. There are many resources available to help get people more comfortable with the PDMP and utilizing it to its fullest potential. If you are just briefly glancing at the PDMP and figuring out the morphine milligram equivalent and moving on with your day, you are not utilizing it to its fullest potential. I know that for many of us, this is a box that we're sort of mentally or actually checking to say, okay, I did this, I met that regulatory requirement, now I can move on to the next step. We need to not forget that it is a clinical tool. There are lots of good training modules out there. The CDC has one. You can find them through many of our professional boards and associations. And then there are two organizations that I wanted to tell you all about. The first here is the Prescription Drug Monitoring Program Training and Technical Assistance Center. This is a grant-funded organization that is designed to improve consistency among PDMPs and promote best practices. So they help guide sort of the development of PDMPs so that they can be a more powerful clinical tool. And they also have really great information if you are licensed in more than one state and want to figure out the nuances between the states. The Prescription Drug Monitoring Training and Technical Assistance Center has really good visuals and different graphics that compare and contrast the different states' PDMPs. The National Alliance for Model State Drug Laws is also a good tool and resource. Like it says in the name, they develop model state policies, primarily to help address alcohol and drug abuse. Great tool and resource if you're looking for some standardized changes in your practice area, proposed legislation, or if you need to dig in and find more tools and resources for a specific like concern in your area. They have tools and resources in there, like it says, for alcohol, for other mental health tools and resources, help standardize some of those ways to track referrals and create opportunities to create an interprofessional team so that you have all of those professionals at your disposal. So Amber is putting really great information for you in the chat. Please let me know, Amber, if I'm missing any questions that you need me to address. We're going to keep moving.
Stevie, there is one, if you don't mind getting interrupted midstream, and it kind of goes back to some things we talked about in the first webinar about prescribing naloxone. Actually, you don't even need to prescribe it in most states. It's a standing order for most states that I'm aware of. And just some questions about what's the dosage that people are, the standard of practice for when you prescribe or dispense naloxone. Is it at 90 milliequivalents or greater, morphine milliequivalents or greater, or is it with every opioid?
So that's a really great question. And thank you, Danny, for bringing that to us. So there are several sort of hard and fast places where I would consider recommending naloxone. Above 90 morphine milligram equivalents, yes, people should always have it available to them. And then below that, depending on the patient age, typically I start looking at about 50 morphine milligram equivalents for risk factors. So if they are on about 50 MME a day and they're on a benzodiazepine, or are they on Ambien, gabapentin, other neuroleptics, anything that is a CNS depressant is usually a trigger for me that I want to look further. I often recommend naloxone in those situations above 50 MMEs and some sort of COPD or asthma where they're on maintenance medications. I would consider it in those cases. And then patient age is really a good determiner of that. The risk for respiratory suppression increases as a patient gets older, and we can start to tip the scales. I always talk to my elderly patients about like the teeter-totter of our organs. And for most of our life, things balance really nicely. And as things change internally, other systems pick up the slack. But eventually in the aging process, that teeter-totter will move, and our liver and our kidney function deteriorates enough that I didn't have a problem 6 months ago, but now I have a problem metabolizing this particular medication or this combination of medications. And so for patients at about 70 and above, or if they are medically frail before then, I recommend naloxone then as well. It is relatively affordable on most insurance plans now, especially if you have the kits available, and is just so easy to offer to people, significantly more easy than an EpiPen. And we wouldn't hesitate to recommend an EpiPen in the case of severe allergy. even though it's pretty cost prohibitive. So I also, anyone who has been recently discharged from a residential treatment program, anyone who has been through abstinence treatment, anyone who is on buprenorphine or methadone products also recommend naloxone in those cases as well, because we know that there are risks there that increase their chance of having a breathing emergency or being around someone else who has a breathing emergency. So those are all things to consider when to give naloxone. It winds up being, I would say, roughly half of all patients where they qualify for that. We have like an in-depth consultation that we do at the pharmacy where we talk to them about having Narcan on hand at home. And about half of all patients fall into that category where one thing or another recommends them to it. And then probably another half of those people will take the recommendation and leave the pharmacy with naloxone on hand.
Thank you for that, Stevie.
You bet. So when we talk about quality improvement and opioids, the very, very first thing we always have to do is get leadership on board. We really want leadership engagement. There's not a lot we can do without support from people in charge, because when we look to improve quality of care, we know at the beginning in particular, it is going to be time consuming for a person to research policies, develop policies, train staff, gather data that we need to assess the quality of our intervention and whether or not it's working. So don't forget step one when you're looking at these things. And then from there, you need to build your team. So a team for quality improvement around opioids typically would involve a provider champion, anybody who is passionate about pain management care in your clinic is a good person to select for this, whether they're an MD or a mid-level. It really doesn't make a huge difference as long as that person has the respect of their peers, and people will trust them to go ahead and move forward with that. Also, you want that team to be interdisciplinary. Whenever possible, when we're talking about opioid quality improvement, patients with chronic pain interact with all of the people in your clinic, from reception to MAs to nurses to the providers, quite a bit more than other patients who interact with our clinics. They're chronic disease management patients, so we see them frequently. We need to touch base with them often to ensure that their treatment is going well. So when you're building your team, it's best to include a receptionist, an MA, those people who are answering the phone, so that as you encounter barriers, you can really come at them from many angles. Because as you make changes to your pain management practices, I have found in every clinic that I have talked to about this, that the receptionist feels like they're bearing a burden, rightfully so, because they're having to communicate all of these changes to these patients. And so better to just include them right from the beginning. It really improves outcomes for patients and keeps engagement for staff. And whenever possible, pick people who are passionate about these things, and then work on your drafted goals. So think about what is important to your community, your patient population, that you could put into place to improve outcomes for your particular situation. When we talk about quality improvement strategies, Mountain Pacific has a plethora of tools and resources to find the right strategy for your situation and your clinic. I'm a big fan of the Plan, Do, Study, Act in rapid cycles. Often when we're dealing with a problem, it's not an isolated problem. There are lots of things that need to be fixed around a clinic or, pharmacy practice setting, wherever you're at. So having these things that can make it bite-sized and help outline how you're going to move through your process is very helpful. I also have on here the continuous quality improvement, where we do structure, process, output, outcome, and then we circle back. I would just encourage everybody to remember, when we're talking about quality improvement never ends in healthcare. We can never reach a point where we're like, we're 95% controlled on our hypertension goals. We've got 78% of our diabetics at A1C goal, and now we can just sit back and breathe. Like, we all know that's not how it works. We have to keep working at it. It's impossible to attain 100% because we've got new patients coming in, things come up, bodies change, but this is a field where we get to come at it fresh every day, and so everything will circle back. And so remember that all of these are looping, and we're never done. So when we talk about these standardized approaches and evidence-based quality improvement areas for opioids, what does that look like? The CDC has several proposed measures for quality improvement metrics around opioids. These first ones on your screen here are for new opioid prescriptions. So right off the bat, I would encourage you to decide, do we want to tackle new opioids? Do we want to look at our long-term opioids? What makes the most sense for our practice? What feels most meaningful is possibly our low-hanging fruit. But when you're looking at new opioids, you can go with a lot of different things. A lot of these do involve chart assessments, just fair warning. There is ways to use data, like you can pull your own record from the PDMP and look at what you're prescribing and to whom. You can look at your average morphine milliequivalent prescribing rates that way. You can do a lot of those in your EHR as well. But when it comes down into some of these things, it does require chart review. If you are fully utilizing your electronic prescribing fields and you are able to use discrete fields and you're not free typing text, it's more easy to mine that data out. But if you find that you are having to free text often, so say that your controlled substance SIGs tend to be detailed and wordy, it gets harder. So utilize the notes section wherever you can for things like dispense date, not to exceed notes, those sorts of things. Whenever possible, you're going to want to use your SIG codes whenever you can. So you're 1 to 2 every 4 to 6 hours. You want that to be in your SIG codes so that that stays mineable data so that you can extract it, pull it back out. That also will allow, if you have morphine milligram equivalent capabilities in your EHR, that will allow it to read it so that it can spit it back at you and track it and do all of its risk assessment tools. Those things are all improving in many of our electronic health records and are your friend. It will become helpful as it becomes more useful. So keep at that. Don't get discouraged is my moral of the story today. This has improved so much in the last 3 years. It's going to continue to get better. Hang in there. So we're looking at, when we look at new opioids, are we prescribing immediate release opioids? We do not want to use long-acting opioids in new patients. That increases their risk of adverse events. Are we documenting that the PDMP was checked prior to prescribing? Some systems can query the PDMP by themselves, and so it will tell you that it was in there and when, and generate a report. Sometimes you need to access it in a separate system and then be sure and consistently document that. You can look at what percentage of patients had a urine drug test performed prior to prescribing. It is a best practice to perform a urine drug screening prior to initiating opioids. And then if they're a chronic pain management patient, you'll want to repeat that at least annually. Just gives us a baseline to let us know what other drugs we might be concerned about, can identify things that maybe we weren't expecting. In my experience, there are definite substance use disorder patients that surprise me. You do not know just by looking at a person what they might be struggling with as far as illicit substances go. And so this is something that is just good standard of practice care. That way you're doing it with everyone. It's standardized. You don't have to think about it. Looking at what percentage of your patients had a follow-up visit within 4 weeks. Are we doing those regular assessments? And when we're doing new opioids for acute pain, how many people are receiving 3 days supply or less? Most of our state statutes will allow 5 to 7 days of opioid for a new onset acute condition. The evidence says that probably they need less than that. We know after about 3 days that risk of developing dependence or use disorder increases. And so that 3 days is the current best practice. It is tougher in rural areas, especially if people don't have a pharmacy in their town. But whenever possible, we should be shooting for less when we're doing acute opioids. Long-term measures have many more recommendations that you can pick from. You do not need to obviously go out and pick all of these. Pick 1 or 2 to start with. Once you've got a good handle on it, you can layer on. Just doing a couple of these really can improve outcomes for patients in your practice. The morphine milligram equivalents are a great place to start. You're already part of a multidisciplinary team here, whether you realize it or not. Most pharmacies have programs in place where they are helping check these things as well. And so you are likely receiving phone calls about these things already. So find those pain points for your community and lean into them. So looking at what percentage of your patients on long-term opioids are on more than 50 MMEs per day. How many are on 90 MMEs per day or more? I like to start with 90 because it's surprising how many people fall into that bucket above 90. And it is difficult to wean people off and taper them down. It can be scary for patients. Chronic pain is serious business. When we talk about these pain management strategies, we don't often get to talk about the other side of things where we have untreated pain, but that is a risk as well. So I recommend starting with those 90 MMEs and then looking at benzodiazepines. You also might find that there are things that are relevant in your practice, like we're not seeing these people back enough, we're losing them to follow up. And now that we have more ability to check in virtually, there can be some flexibility to meeting with those patients. So here are more recommendations for those long-term opioids. It includes things like counseling on risk versus benefit at least annually, continuing that urine drug test at least annually, looking for referrals for non-pharmacological therapy such as PT, OT, acupuncture, massage therapy. We'll talk more about those things in 2 weeks. And then looking at how many people were counseled on naloxone and either prescribed or referred for naloxone. Lots of things that can be tracked and measured there, which are proven to improve outcomes and reduce the risk of development of opioid use disorder or early identification of opioid use disorder. When we're prescribing opioids, we always have to think about what it's going to look like when we take the person off of opioids. And so planning for that needs to be part of our treatment. I really like to recommend starting with morphine milligram equivalents because the risk of mortality is quite high when we're above 90 MME a day. It is something that can dramatically impact families and communities. So any of our patients that are taking opioids for longer periods of time or in higher dosages, can increase their risk of opioid use disorder, overdose, and death. We are starting to see the number of opioid prescriptions really dramatically come down. They peaked 2010 to 2012, and they've been declining steadily since 2012. In that same time, though, we're not actually seeing the morphine milligram equivalent prescribed per person come down. It is in 2018 when this study was conducted, it was still 3 times higher than that of 1999. So we're still, those patients who are receiving opioids are getting opioids at a higher dose than they probably should. There is no evidence to suggest that MMEs above 50 to 90 morphine milligram equivalents a day provide better pain relief than those lower MMEs. So we're trying to flood those morphine receptors that we talked about last time with more opioid, and it's not providing more pain relief, but it is making it harder for that patient to breathe. One pitfall I hear in clinical practice a lot is, well, they've been on that dose for a long time and they're fine. And that is wonderful that they have been fine thus far. That does not necessarily mean that our job is done. There are going to be those rare exceptions where someone is a rapid metabolizer, or we truly can measure the benefit to them at a higher dose, and we have really put in a lot of strategies to mitigate their risk. But those people are going to be by far the exception. Most people, all we're doing as we whack up the opioid dose is increasing their risk of having a breathing emergency and increasing their access to a medication that could harm them without any evidence of benefit. So everything we're not supposed to do in medicine. When we prescribe dosages at or above 15 MMEs a day, we are increasing that patient's risk of overdose at least twofold. If they are above 65, if they have comorbidities such as obesity, heart disease, lung disease, if they're on central nervous suppressants, that risk goes up even higher. And so there's every incentive to make sure that we're reining those things in. It's very easy to start with new patients so that we are giving them those lower doses right away and not putting them at risk. And then once you've got that handled and it's standard of care in your clinic, you can start moving toward, all right, how do we bring our chronic patients back down to an area where their risk is better managed? Because it does take time to taper people down. It takes time to help patients feel comfortable with that and empowered in that decision. Chronic pain is multifaceted and can cause lots of different thoughts and feelings for patients. It's very normal for a chronic pain patient to have fear of pain because it hurts and it makes them sad and it makes it hard to sleep. And these are real things. So we do have to give those patients time and resources, but should not be a deterrent from improving that quality of care. There are many good risk assessment resources out there. More and more electronic health records are adopting the opioid risk tool and putting it into their opioid modules. You can see this in Cerner, Epic, eClinicalWorks. All of those are bringing in the opioid risk tool. This is a brief 1-minute screening that is very accurate and lets us know if a patient is at risk for opioid use disorder, either right now or in the future. There are many others to pick from as well. The CAGE Aid is a 5-question tool that screens for lots of different substance abuse. And then we also should think about whether or not you want to implement SBIRT. So screening, brief intervention, referral to treatment. This gives us tools and resources so that if we identify a patient who has current substance use disorder, we can begin an early intervention and then get them into treatment for those substance use disorders. Very important. So that opioid risk tool, like I said, is available in many modules and many electronic health records. It's pretty easy to switch on. Typically, it does not incur an extra fee, and you can set it up to where it will trigger if you are going to begin an opioid pain management prescription. There are other electronic clinic decision support tools out there as well. More and more of the EHR have integrated PDMP links. This is primarily for states that are signed up with APRIS Health. More than half of the states in the nation are contracted with APRIS, and they are their PDMP vendor. They have many connections now where you can get PDMP reports directly into your EHR. Typically, it does have to be those larger EHRs, and like I said, it's not available in every state, but it is becoming more frequent, and most states are moving toward that. So if your state is not there yet, don't lose hope. It is likely coming, as quickly as these things move along. Like in my state, I'm cynical because I think it will be a decade, but it's very valuable for people where it is available. And like I mentioned at the beginning of this, not a huge burden if it's not available to you. That ORT, the opioid risk tool, is available. Default order sets are another thing that can be very helpful. So if you have a rolled ankle, a common procedure that is occurring, you can put in those order sets. You can trigger them to include things like, did we counsel on naloxone? Set up your patient education handouts. When we're talking next time about multimodal pain management, it is much more valuable for a patient to leave with a good set of stretches and tools or suggested exercises for their particular pain than for us to just sort of hastily sketch it out in 3 minutes. It's very easy to walk out of there and not remember a single thing that our provider has told us. So those handouts are very key. Patients really like them, and they will read a handout from their medical provider quite a bit more than something they receive from like their pharmacy. And then also consider adverse event flags. So if a patient is on chronic pain management and they are seen in your clinic for shortness of breath, trouble breathing, cyanosis, make sure that those things flag so that you can then begin assessing, because probably that is related to their opioid. At the end of all of this, I would say talk to your vendor whenever possible. More and more tools and resources are available when we are prescribing opioids, and they are integrated into our electronic health record. It changes often and regularly. So talk to your individual vendor, make sure you know what is available to you and what the cost could be. I do find that most often these particular modules around opioids are free. You just have to switch them on. And then Deb Anderson has asked, what MIPS credit can they get for using the opioid risk assessment tool? I'm not, gosh, it's been a minute since I've looked at those MIPS. I know that you get credit if you can prove that you're accessing your PDMP regularly, which is usually very easy to do. You can generate your own report for how you access. I will have to look into what credit they might get.
I can take that one. Yeah, I can take that one. At this point, I will do a more in-depth review of the quality measures from a quality standpoint, the quality piece. But there is not one that I saw on a quick search during this webinar. However, implementing an opioid risk tool certainly could be part of your overall improvement activities. Also remember that the PDMP, consulting that is actually bonus points on your promoting interoperability. I included lots of that kind of information at the beginning of the webinar, so you can scroll up through the chat. But if you do have specific questions, feel free to just reach out to me individually and we will make sure and get that answered. And for Deb, I will do a more in-depth review of all of the quality measures. But I think that that is not part of the quality measures, if that answers your question. raise your hand if you want us to promote you to a panelist so that you can clarify.
Yeah, so we are to the portion today where if you have questions, please do raise your hand. We can promote you to panelists, or feel free to type them in chat.
Well, it is 4 o'clock, so feel free to reach out to either Stevie or myself if you have specific kinds of questions that you would like us to follow up on. And I hope you all